You're listening to the Future Tech Podcast with Richard Jacobs. Future technologies such as artificial intelligence, stem cells, 3D printing, gene editing, Bitcoin, blockchain, the microbiome, quantum computing, virtual reality, and exploring space are much closer than you might think. In fact, many early versions of these technologies are in play right now, and the companies that are using these technologies are the focus of this podcast. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a thorny medical problem. Remember, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you enjoyed the podcast, please listen, subscribe, like, and tell your friends about it. Thank you. Hello, this is Richard Jacobs with the Future Tech Podcast and also Future Tech Health. And I have three guys from Delta Waves. The website is deltawaves.org. We're going to talk about sleep medicine. We have Adam Moseley, Dale Moseley, and Joe Schultz. So thanks for coming, everyone. How you doing?
Great. Thanks for having us.
Yep. Happy to be here.
Yeah, well, if you would, in order, just, let me know, what you do and what your position is at Delta Waves, and we'll start with there.
Yeah, so I'm Joe. I'm a certified clinical research coordinator here, and I specialize in the sleep-related research that we do.
Okay.
I'm Adam. I am a registered polysomnographic technologist, and I manage a good chunk of the sleep department here.
And if Adam seems a little tired, it's because he works night shift.
I just woke up.
Oh, no.
And I'm Dale, and I founded Delta Waves at a hospital in Colorado Springs, and saw a need for collaboration, also research of sleep medicine. It seemed to be three different parts that were happening separately, and we were able to bring it together under one.
Okay, well, very good. So what's the premise of Delta Waves? What's the company about? What do you guys do?
So Delta Waves, we were founded back in 2005, so we've been around a little while. And like I said, I was a former sleep technologist, and basically I was seeing a lot of folks go to the hospital getting for disorders diagnosed, and they were having trouble with their treatment, really struggling with their CPAP, like BiPAP, and their oxygen therapy. And so I thought that if we could develop something that could tie not only the diagnosis but the treatment of disorders together, be serving our community better in our patient population. So launched back in 2005, and very quickly, a rapidly evolving field. And so that's why we're here today. We have some exciting things to be part of in terms of being involved in the cutting edge technology with sleep medicine. We're fortunate enough to be able to do trials of different types of CPAP machines, different equipment, as well as masks that are used in sleep apnea. One of the biggest problems with patients and compliance is these masks that they have to wear, for the treatment of their sleep apnea. Oftentimes they don't fit quite right. We've been fortunate enough to be able to have, allow our patients to try masks that aren't even on the market yet. So anyway, that's kind of the thumbnail of how we came about and what we do.
Okay. So your focus is treatment of sleep apnea through various CPAPs or BiPAPs or other types of machinery, right?
Yeah, that's probably, it's multifaceted. We also, insomnia, there's ovary disorders. So we are able to diagnose most of those sleep disorders. Maybe Adam can speak more on that.
Yeah, so we run sleep studies six nights a week. Essentially, we hook people up with a bunch of wires and tell them to go to sleep as normally as possible, and then we just monitor their sleep during the night, looking for multiple different sleep disorders. Like Dale said, we can detect up to 60 of the 80 sleep disorders. So if there's anything going on during the night, we're documenting that and letting doctors know. And throughout the night, we can treat 2 sleep disorders in lab. So if the patient's oxygen is running low, we can put them on supplemental oxygen. And then also the treatment of sleep apnea through using CPAP or BiPAP or ASV. Being in Colorado, we see a lot more cases of high elevation central sleep apnea, so we end up using advanced therapies quite often. So that's kind of unique to being in a higher location as far as elevation goes.
Yeah, what is high elevation related sleep apnea? Can you talk about that a little bit?
Yeah, so with higher elevations, the oxygen that someone breathes in, they're not getting as much oxygen to the lungs. And so what happens is you end up breathing a bit faster to maintain oxygen levels during sleep. The problem with that is as you exhale more, you're exhaling more CO2 or carbon dioxide, which that creates low CO2 levels. And the brain, to overcompensate for that, or the brain tells the body to not breathe to make up for the lack of CO2, and you end up having what's called central sleep apnea. Well, the problem with that then is as you're not breathing, your oxygen will dip, and then your brain goes, oh, I'm not getting any oxygen. So you start to hyperventilate, and you end up burning off all that CO2 your body was trying to retain, and it's this endless cycle where the body's trying to find the right tidal volume. So we have to use more advanced therapies like ASV, stands for auto servo ventilation or adaptive servo ventilation, depending on what brand of company you're working with. But essentially, this is a ventilator that evens out your tidal volume. It gives you deeper breaths and slows your breath rate down to maintain oxygen, but also maintain proper CO2 levels. One of the biggest problems we have with these machines is they end up leaking. Either the mask doesn't fit right, or someone is breathing through their mouth with a nasal device, which doesn't quite work all the time. So that's where Joe comes in. He does these trials. Joe?
Yeah, so we work with the top two manufacturers of sleep-related equipment, CPAP machines, BiPAPs, ASVs, and then masks. And we get to test out their new equipment. And a lot of times that involves masks that aren't on the market yet that might be a better fit for patients. So we can kind of alleviate that issue of not having the right fit, and help these patients compliance and help that treatment start to work for them.
Well, that's what I was going to ask you. With traditional sleep apnea, what are the problems people have? I've heard it's difficult to get used to a CPAP. So what does that mean, difficult to get used to it? What are the problems?
Well, it depends. Some people have a hard time getting used to the pressure. Those people tend to have higher pressure levels. But most complaints that I hear from CPAP is that it's just not comfortable. They have to strap these masks on super tight so that it doesn't leak out any air. And also, some people don't actually have the right pressure, and they haven't been, over time, they need a different pressure. And so sometimes just another sleep study is required to get compliance back. But yeah, the main issues we have are just it's not very comfortable to wear, or the pressure seems like it's too high, or sometimes I get complaints that the pressure is even too low and they feel like they need more air. So those are the top complaints that I hear about.
Well, what happens when the pressure is too high? Like, what will the person experience? Like, do they find it hard to breathe? I don't know, do they not able to relax and sleep? Like, what happens to them?
Yeah, so that sometimes high pressures are necessary, and for that, it is a little bit unfortunate, but there are comfort settings on CPAP machines and BiPAP machines called ramp setting, where you can push a button on your machine and it will drop the pressure quite low, so that the person can fall asleep and the pressure will raise gradually. One of the biggest things we do in lab, if someone complains of high pressures, is we can switch to BiPAP, which is essentially instead of, so CPAP, it stands for continuous positive airway pressure. BiPAP is actually two pressures. So you have one lower pressure, and as a patient inhales, it goes to the pressure needed to clear the airway. And then as the person exhales, it drops back down to that lower pressure for comfort. So those are the main things we do for high pressure levels.
I was going to ask you, what happens to people's, so apnea is because people's soft tissues relax when they sleep and collapse, right? The airway collapses?
Yeah, so there are two main kinds of apnea. There's obstructive sleep apnea and there's central sleep apnea. So what I was talking about earlier was central sleep apnea, where the brain sort of tells your body not to breathe. With obstructive sleep apnea, which we see very often as well, is the soft tissue. It could be tongue, tonsils, adenoids, anything in the throat or the airways that is over-relaxing during someone's sleep and then collapsing down onto the airways, preventing a person from breathing. Could be a deviated septum or something like that. Either way, positive pressure generally fixes or treats obstructive sleep apnea, whereas positive pressure, if it's just CPAP, tends to aggravate central sleep apnea. So they are treated, central and obstructive apnea are treated very differently.
Okay. Do you notice that the amount of pressure required for someone to keep their airway open in obstructive sleep apnea, for instance, changes as they go through different cycles of sleep or stages of sleep?
Oh, definitely, yeah. So REM sleep is a state of sleep where your body actually produces a chemical naturally that paralyzes you, so that you don't act out your dreams, essentially. What happens is if your body's, all your muscle tissue is the most relaxed in REM sleep. So you end up having generally more sleep apnea in REM sleep. Also, supine or laying on your back, you can have worse apnea if you're on your back. These are, it's very important during a sleep study to be able to tell when someone goes into REM sleep, because you may have to increase the pressure a little bit more aggressively if they start having more severe apnea, because you are, during a study, you're changing the pressures to try and find an optimal pressure for that person. And different pressures vary from person to person too. I've had patients that are 300 pounds and they end up needing only very low pressure, and I've had quite the opposite, where you have a very slender person who needs 15 centimeters of CPAP. So it does vary in different stages of sleep, and different positions all play a part in that.
Well, is there a way to get feedback from the person as they're sleeping without them being in a lab where the CPAP can adjust the pressure depending on the stage of sleep and the particular circumstance of what's going on at that moment?
Yes, we can use auto CPAP, where the CPAP machine automatically adjusts pressure based on how the person's sleeping, and it may increase the pressure in REM sleep if they're having more apnea. The one problem I see with these auto machines is they do wait for you to have an apnea before it increases the pressure to adjust for your apnea. So that means that you're still going to be having apnea. That's why I think sleep studies are very important, so that someone can come into a lab and find the pressure at which any position or any sleep stage, the pressure that person needs to maintain sleep throughout the entire night. So we can't use auto CPAP with comorbidities for patients without any other health issues.
Okay. I just didn't know if there's again, ideally it sounds like one pressure is not enough, so it has to be multiple pressures that change throughout the time.
So some people, sometimes auto CPAP really does work for some people. We do run into a lot more issues with auto CPAP, especially when a person has central sleep apnea, for example. Auto CPAP, they're just now getting into some algorithms where it can detect central apnea and it won't increase for central apnea. But basically, if you increase a pressure of CPAP for a patient who's having central sleep apnea, that central apnea will worsen, and sometimes machines will just keep increasing and increasing and increasing because it thinks they're having apnea or obstructive apnea when they're actually having central apnea, and it's just making that central apnea worse. A person, as they're exhaling against pressure, end up retaining CO2, and it causes some tidal volume issues, which again aggravates central sleep apnea.
Gotcha. Okay. So what's the newness? What are the new masks about, or what do the new CPAP machines look like? What do they do that's different?
Like Adam touched on, the main thing with the machines is the algorithm that they operate on. So if it's detecting the difference between a central apnea, hypopnea, and obstructive apnea, if they're having periodic breathing or mask leaks, it's all about the software on the machines. Functionally, they operate mostly the same. All CPAPs are going to put out positive pressure. BiPAPs are going to have that variable pressure than ASVs with the ventilation. But the new masks, the main thing is going to be the shape and the comfort that they shoot for. So we'll get to try out, is this a different type of material? Is it a gel or a silicone? How do we make that more comfortable when it's on the face, touching skin, not causing allergies? And then also, how do we get the right fit? That's another thing is, there's 200 types of masks out on the market. And the reason for that is because everybody's a little bit different. If you have a bigger nose or cheekbones or your chin, your lips, all the different facial structures, require a specific mask for that. So the newer technologies, without going into too much detail and getting in trouble, is creating, masks that are custom for each individual. Essentially looking at that person and identifying that facial structure and immediately knowing which mask is best, without having to trial and error, dozens of masks some patients have, unfortunately.
Yeah, why couldn't why couldn't there be a mold and you make a custom mask? It seems like that wouldn't be, too difficult.
Right. I think maybe something more electronic, like a, face scanner, 3D mapping would be a little quicker than doing mold of the face. So I think that's probably where we're going to start heading, is where you can walk into a store and get your face scanned and thing printed, 3D printed for you. That would be ideal.
Yeah, or where the sleep study's done. I mean, that
Right.
seems like to be an ideal place. If they're gonna have you there and all that, they should be able to do a mold of your face and make something custom.
Right. Ideally, we could do it fast enough. You would walk out that morning with a custom mask.
Yeah. Okay. Any other trends you're seeing? Like you've been doing this, I guess, for a while. What is sleep apnea increasing, or disorders changing the prevalence of them or the nature of them?
I think in lab, we're starting to see a lot more difficult cases. The reason for that is, I believe, insurance companies are beginning to restrict how much they're approving sleep studies, and they're approving home sleep studies instead. So a lot of people are getting tested at home with home sleep study device, and essentially that will rule out apnea before they would have to come in for a sleep study. So if someone were to have sleep apnea or a sleeping disorder, low oxygen levels, they would end up sending them in lab after their home sleep study, because then they've confirmed, okay, this person really does need a sleep study. So we're seeing less and less easy studies that go through, and we're seeing a lot more challenging studies dealing with central apnea and severe obstructive apnea. Again, with these home sleep studies, a lot of times doctors will just end up putting these people on auto CPAP. So they never even come to a sleep lab for a sleep study to see, what pressure they might need. They just end up on auto CPAP after they've determined there's mild sleep apnea. A lot of times with mild sleep apnea, a doctor can, or a sleep specialist can say, this person might only need auto CPAP. So
That's really one of the problems with the current trends, Rich, is with insurance making it more difficult for patients to get a full in-lab sleep study, they're approving home sleep tests, which are very limited in their scope and what they can diagnose.
Yeah,
So what will happen is,
what's the trade-off between a home sleep test and one in the lab? Like, what can't you do, and what problems would that cause?
so typically with a home sleep test, there's limited. You don't get the EEG channels. So you can't verify if they're actually in sleep or not in sleep. You can't verify whether they have central apnea versus obstructive sleep apnea. Basically, it rules out. It can potentially rule out sleep apnea and rule obstructive sleep apnea with a certain degree of Adam has something to add to this.
So in lab, I mean, we put monitors on your legs. We're looking at the heart. We're looking at the respiratory effort. We're looking at, we can detect snore. We can pick up muscle tone in the chin and the face. We're looking at the brain waves, eye movements. A home sleep test is essentially oxygen levels and airflow. So you have 3 or 4 channels at the most with a home sleep test, and they're really only looking for any sort of breathing disorder versus anything that can go wrong during sleep. So we have 32 different channels in the lab, whereas a home sleep test has 5 or 6.
What do you do if is there good information gathered from a sleep study, even if you don't have apnea? And if someone doesn't have apnea, but I don't know, let's say other things are going on, can you help them, or can you make recommendations?
So the most common thing that I see in lab is just chronic low oxygen. So someone's oxygen is low, either that, and in which case we would just supply supplemental oxygen. We also see the most common thing is periodic leg movement disorder, or syndrome, I think it is now, it changed, where someone's twitching their legs during the night, and that can happen every 30 seconds, or actually every 90 seconds or less. That's waking them up every other minute in their sleep, and usually that's an electrolyte deficiency, most commonly iron or potassium, in which case a lot of doctors do some blood cultures. Sometimes that results in some changes in sleep. The medication for that readily available. Also, we see REM behavior disorder, which is where someone doesn't actually have a chemical that paralyzes them in their sleep, and they end up acting out their dreams. That's a very interesting disorder because it has some connection with on the Alzheimer's and stuff like that. So some of these disorders you can sort of help prevent some big issues later on down the road.
I mean, is it rash to say that everyone should have a sleep study as they get older? Let's say every few years to see what's going on with them. Is it as good as I know I'm really speculating here, but is it better even than a prostate exam, for instance? Is it just a good diagnostic?
I think
for overall health, you think it's a very good. You think it's a good diagnostic tool? I don't know.
I think so. I don't know if I would say it's better than prostate exam or something like that, but I think if you think there's a chance you have that you have a sleeping disorder, or that you don't sleep well, or I'm just one of those people that doesn't sleep very well at night. It's not just that you're one of those people. There's a chance there's something going on in your sleep, and it's affecting your health and your day-to-day life. So I think it is valuable and important that if you don't sleep well, or if you don't think that you sleep very well, talk to your doctor about having a sleep study, because they can really change your life.
Yeah, Rich, just maybe to tie into what you were asking before about the current trends. So what I was saying before is typically with the home sleep test, oftentimes what are happening just because of insurance issues is a patient will get a home sleep test, the doctor will suspect sleep apnea, and then they'll get sent home an auto CPAP. This is very common, especially for younger generations, maybe 40 years old, where they don't have other health issues. The problem with this is oftentimes these patients end up not being compliant because they don't get the education that is required to really be successful with their CPAP treatment, and or they're not being treated properly because AutoPAP is limited in its scope. What's ended up happening is a lot of patients that really need treatment for sleep apnea aren't using it because the patient has failed the treatment compliance reason. So I just really encourage, patients who are struggling with their sleep issue not to just throw the baby out with the bathwater, so to speak, but to really push their doctors for an in-lab study if the home sleep test and AutoPAP isn't working and they're still sleepy, because insurance will cover it if the AutoPAP is failing or they still have symptoms. But it really takes the patient to advocate for themselves to get in and keep trying different masks. If the mask is leaking or it's uncomfortable, just keep pushing their medical equipment supplier for trying different types of masks until they get something that works for them. Because it's really crucial for their overall health, like Adam was.
Yeah, we try to educate all our patients in the lab that sleep apnea does not only affect how well you sleep or how alert you are during the day, but if you're not breathing, your oxygen's going down, and that really affects your heart. And this can lead to high blood pressure, heart attack, stroke in your sleep, and a lot of deaths that happen in sleep are being linked to untreated sleep apnea, where their heart has just over time not been getting enough oxygen, and so it's really put a
detrimental
to
the function of it. Yeah.
Yeah, I mean, if you're stopping sleeping, I would think it's a horrible stress to your system. And if that happens 10, 20, 30, 50 times an hour, if it happens hundreds of times a night, that sounds pretty horrible to me.
Yeah.
Well, if you have ever actually watched somebody that has sleep apnea sleep or try to sleep, it's actually quite disturbing.
My dad, he would gasp and all that. I've seen it personally. Yeah, it's terrible.
Yeah. Yeah, and I just had someone the other night that had over 130 apneas per hour. And to mark an apnea, it has to be 10 seconds long, according to the American Academy of Sleep Medicine, which I know you interviewed Dr. Krieger the other podcast, a couple podcasts back or something like that, and he's right. It has to be at least 10 seconds to mark, and so that's like 2 breaths, 10 seconds of not breathing, 2 breaths, 10 seconds of not breathing, and that goes on until we can put them on CPAP. So we have to see a certain amount of apneas being sleep techs to make a diagnosis. So we have to sit there and wait for these people to essentially qualify for the CPAP machine. But I mean, as soon as I put the CPAP machine on this person, they start sleeping like a baby. So
That's crazy. What happens if you have a subclinical apnea? The person still stops breathing, but it's only 7 seconds, but it happens 20 times an hour. What do you do?
So
do you
usually
say, "Oh, you're fine," or what do you do?
No, so that is very, very, very rare. When I see sleep apnea, and I've been a sleep tech now for almost 8 years, when I see sleep apnea, it is almost always 10 seconds. That's generally how long it takes the brain to recognize the lack of oxygen that it's getting before it realizes, oh, I'm not breathing. I should wake up and take a breath of air. So there are types of apneas that are shorter, but it's very rare. Like I said, we don't see that very often, and most of the time they are at least 10 seconds, if not longer. So most of the time longer.
Okay. Yeah, I was just wondering, because I figured that would be disruptive too. But yeah, that's weird that the 10-second mark seems to be a threshold that's so common. So what do you see? Either people don't have apneas at all, or they have them more than 10 seconds, or it just doesn't affect a person badly if it's less than 10 seconds?
Yeah, it is like either they don't have sleep apnea, or it is generally always around 10 seconds long. And for the most part, we see if someone has sleep apnea, doctors start being concerned about sleep apnea after someone has had over 5 apneas per hour. Now, moderate sleep apnea is anywhere from 15 to 30 apneas per hour. severe apnea is anything over 30 apneas per hour. So if you have more than 5 apneas per hour, you could have symptoms the same as if someone who had over 30 apneas per hour, which is kind of odd, but it is the case. You know, if you're waking up more than 5 times an hour, you're probably going to be tired during the day. So generally, people and insurances will cover CPAP machines for people who have AHIs or RDIs, which are the apnea hypopnea index over 5, which is just apneas per hour.
And in a lab, I mean, you know, it seems it's a different environment the person sleeps in, different pillow, different bed. They're hooked up to all these instruments. They probably mentally are like, oh my God, what if I have sleep apnea? How do you get good data? Do they still sleep okay, or is the whole thing just, I don't know, like how do you get good data?
Yeah, so technically all we need is 2 hours of sleep to diagnose a sleep disorder. We generally get more, but we will, in a healthy person, we will see hopefully every stage of sleep within 2 hours. And if we don't, usually something is preventing you from getting to that stage. One of the biggest things we do here at Delta Waves is train our techs to be friendly with people that are coming in. Our labs are clean, cozy. They look like a nice hotel room that you come in and we don't bring the wires in until, you know, it's time to hook them up. We have conversation with them while we're hooking them up. You know, it's not like this weird two-way mirror where you're looking through and like watching someone sleep. When we hook someone up with all these wires, we just say, you know, all we look at throughout the night is a bunch of squiggly lines. You know, we're not actually eating popcorn and watching you sleep, you know. So the environment here at Delta Waves is very relaxing and as comfortable as it can be under the circumstances. A lot of people that come through end up saying, well, that wasn't as bad as I thought it would be, even though it was not great.
Plus, Rich, it's kind of like going to get your hair done, you know, when your hairstylist is through your hair, it kind of makes you sleepy. So you're putting all the EEG wires on their head, and it's kind of making them sleepy. Plus, half these people are sleep deprived anyway, so oftentimes they're falling asleep in the chair while you're hooking them up.
Yeah.
All right, well, very good. So what's the best way to find out more about your work and, you know, for people to get in contact if they want to interface with you and talk to you?
Yeah, so the best way is just to go to our website at deltawaves.org. You can also call our office if somebody's local and wants to schedule an appointment. That's 719-262-WAVE or 719-262-9283.
Well, that's great. Well, Adam, Dale, and Joe, I really appreciate you guys coming. And you know, sleep's super important. So I'm glad that we took the time to talk about this. So I appreciate you being here.
Thank you, Rich. Appreciate you having us.
You're listening to the Future Tech Podcast with Richard Jacobs. Future technologies such as artificial intelligence, stem cells, 3D printing, gene editing, Bitcoin, blockchain, the microbiome, quantum computing, virtual reality, and exploring space are much closer than you might think. In fact, many early versions of these technologies are in play right now, and the companies that are using these technologies are the focus of this podcast. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a thorny medical problem. Remember, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you enjoyed the podcast, please listen, subscribe, like, and tell your friends about it. Thank you.